Thank you, Chairman, and the organizing committee, and also the president of the SIOP Asia. I'm happy to share some information about the ependymoma with the Asian colleagues and the friends. So why pediatric oncologists are talking about ependymoma? You may wonder, because this is a primarily surgical disease in the past. But now more and more information coming, and the pediatric oncologists, as we are here, will be involved and will make impact. So in 15 minutes, I try to give some information, and hopefully, end of the presentation, you may understand why you guys need to be involved in the future. Okay, let's start. So, we have no disclosure. So ependymoma is internationally the third most common brain tumor in the pediatric population. But as Michael told, in some of the Asian countries, actually germ cell tumor are more common than ependymoma, so it might be the fourth. But anyway, it's after the gliomas and after the embryonal tumor, ependymomas are commonly we encounter. And where it occurs, as we know, ependymomas are more prone to the posterior fossa than supratentorial. And also, ependymoma can happen in the spinal cord. So, and approximately like 10 to 20% of patients have a metastasis as a diagnosis. So the MRI of the spine is important. So histologically, actually, ependymoma has actually 4 subtypes in 2007 WHO. But the grade 1 ependymoma, which is a subependymoma, and the mixed papillary ependymoma, is actually easy to distinguish from the other grade 2 and grade 3. And usually people think these are kind of separate entities. But ependymoma and non-plus ependymoma, these are the problem, but it's very difficult to distinguish even by the very experienced pathologists. They can either misdiagnose or subclassify. Actually, there are some study going that using the multiple world-famous neuropathologists to diagnose the blinded grade 3 and the grade 2, and actually the discordant rate was very high. So it's kind of, these two, grade 2 and grade 3, are kind of in continuum, in the, like a graduation. So there is no clear cut-off recommendation so far. So, but the biology study comes, lately, like last 5 years, there are many papers of the very nice science about the ependymoma comes. And the last paper in 2015, they claim the ependymoma has 9 subtypes, more than medulloblastoma of the 4 subgroups. 9 subgroups, so we will be completely, at a loss. But good news is actually these 4 of spinal tumors and the subependymomas are not really encountered by the pediatric oncologist. So at the moment, we need to think about only 4 subtypes, same as medulloblastoma, easy, huh? So we can talk about these. So in 2011, the Toronto group and Heidelberg group actually found 2 subtypes of this is a posterior fossa ependymoma. So using the expression profile of the microRNA, they can easily divide 2 subgroups of the posterior fossa ependymoma, and there are some genes representing of each subgroups. And later, and in the same paper, they also found some characteristics of these 2 types. Actually, those are group A, they named group A is a ependymoma with a younger age group. And then group B is actually older and adult ependymoma group. And the clinical outcome is very different. Group A, which is a younger age group, has a worse prognosis, both in overall and progression-free survival. And then they did at the time, they did a copy number analysis using some microchip. And then they found group B as an adult tumor has a lot of the chromosome aberration, which is a loss or the gain of the many parts of the chromosome. On the other hand, group A has a relatively clean or silent genomes. And also they, in the later people did a whole exome and whole even genomic sequencing of the ependymoma, they didn't find any single recurrent mutation, which is very unusual for the cancer cells. So the genomic doesn't actually, at this moment, genomic didn't explain why these two groups are so different. But they also use the different molecular techniques, which is a whole methylation array. So when they took a look of the methylation profiling, these two groups are also different. So group A has a more, these CPG island methylation profile compared to the adults. What this means is a very long story, make it short. This methylation profiling actually activating some of the histone modulated gene, which is maybe the kind of reason for the aggressive characteristic of this group A. So at this moment, people are trying to attack this molecular target of the histone modification genes. Then, let's switch gear to the supratentorial tumor, because supratentorial and posterior fossa ependymomas are totally different animals that people already know. And then they did a genomic analysis. As I said, there is no recurrent mutation, but they found nothing in the posterior fossa, but in the supratentorial tumor, there are a lot of these small fusion genes called the RELA gene, R-E-L-A. These genes are involved for the fusions. And also there is a YAP. This is a little bit blurred, but there are some YAP here. Yeah. There are some YAP or YAP fusion, these four. So these are mutually exclusive. So they found the two groups in the supratentorial, those RELA fusion types and the YAP fusion type or fusion negative type. And for those RELA genes group, there are some interesting things going on in the genome. This is called the chromotripsis, which is a whole shattering of the chromosome, so which has like a broken down and fused together, broken down, fused together. Very complex genome, which include this RELA fusion. And this is a driver, because if you put these fusions, RELA or YAP fusion into the neural stem cell, you can easily make the ependymoma by one only fusion, which is very characteristics of these tumors. And then, if you use those methylation array, now they can divide into the 9 subgroups. So what does this mean? Hopefully, we can use this information to bring the new treatment, new molecular targeted treatment, or new, the histone modifying treatment. Hopefully, we can have a better treatment in the future. So let's go back to, and then this subtype has a clearly different prognosis compared to the, this is a supratentorial, like a YAP one, and the RELA. RELA has a worse prognosis in the supratentorial, and ependymoma group A, group B, in the posterior fossa, there's a totally different outcome. So, let's go back to the clinic. So I tried to show 2 cases which recently I experienced in my hospital. So the case 1 is a supratentorial tumor. So 2-year-old girl came with a headache for 1 month and ataxia. So the local hospital took the CT scan, showed a mass. So patient came to me. And some clinically significant thing is she has a big head and some left leg decreased strength. So this big tumor, heterogeneous tumor in the MRI T2 has a location of the right supratentorial and has a restricted diffusions and a lot of the enhancement by the contrast study. So on day 2, our neurosurgeon made a gross total resection, which is good. So clearly there is no apparent residual tumor by the contrast study. And the pathology came back with anaplastic ependymoma, which is a WHO grade 3, which has a relatively high MIB1 index, and you can see some of the division of the cells, and then pattern is not clear as a grade 2 ependymoma. So the question is, so supratentorial anaplastic ependymoma post-gross total resection, what do you want to do? So as a standard, we offered focal irradiation for this 2-year-old girl immediately after surgery. Patient declined. It is too toxic to the 2-year-old. We agree. So we also offer alternative option to give some chemotherapy until the kid get up to like 3 to 4 years, which is permissive for the focal radiation therapy. But family decided not to undergo, even though they went to the 2 other different institutions, which is famous for the neuro-oncology, and got same recommendation for radiation, but they refused. Unfortunately, 4 months after, the tumor recurred in the locally. So and the diffusion, it's clearly this is a focal recurrence. And we did a second gross total resection. At the time, patient and family agreed to undergo the radiation therapy. But at the time, patient also requested the proton therapy. We had to send the kid to the other state to receive the proton therapy. But finally, she got the 55.8 gray equivalent proton therapy. And so far, for 28 months since diagnosis, she's maintaining second complete remission. But we don't know, because ependymoma, you need to follow at least 10 years to say it's cured. So supratentorial tumor post-gross total resection. So there are some observations that some of the ependymoma can be cured by purely only by the surgery. So this is an NYU study. They have some protocol after the gross total resection of the either supratentorial or posterior fossa. They can just observe without do anything. And there are some survivors without recurrence. And most of them actually supratentorial. So from this observation, actually COG took some protocol to give one arm for the supratentorial GT, gross total resection 1, which is a very clear gross total resection, and only for the grade 2 tumor. So they actually they made an arm. So for this protocol is not open for the final result, but there is a preliminary result that among 11 patients with supratentorial grade 2 ependymoma who achieved the gross total resection, only two local relapse within 12 months, and both surviving for 18 and 15 months after resection and XRT. So which means 9 patients are so far surviving at that time of the preliminary report without any recurrence, which is promising. But our patient had a grade 3 tumor. Maybe we should have push more for the radiation therapy up front, which we don't know exactly is it true or not. For case 2, I'd like to show some case of the posterior fossa ependymoma. This is a 1 year, 10 months old boy, came with a vomiting, irritability for a month, and ataxia. So the local hospital took the CT scan, showed the mass, and the patient came to me. And then patient had a left incomplete mild central facial nerve palsy at the time. So tumor was here in the posterior fossa, a little bit enhanced, not much. And then MRI T1 showed some mass. At the time, there are some concern about the increased pressure. So we did a third ventriculostomy first and put some reservoir. Then this is a mass, again heterogeneous by T2, more right side, very adjacent to the brainstem. Actually, the midbrain and the pons are shifted to the left. Then MRI diffusion has a very high restriction of the diffusion. And let's contrast here. So day 16, after we kind of control increased blood pressure, increased intracranial pressure, so near gross total resection was done. Our neurosurgeon said, during the surgery, there is some difficulty going to this area of the just adjacent to the midbrain. There are a lot of the cranial nerves they can see. They are kind of afraid of, taking off all the, important cranial nerves. So we have some residual. And the diagnosis was ependymoma grade 2. It's a relatively, good pattern of the ependymoma. Should perivascular should rosetta, and Ki-67 midborn index and only 3% compared to the 20% of the last case. So infratentorial ependymoma post near total resection, what do we do? So but patient already have a new onset multiple cranial nerve. He came with only mild facial nerve palsy, but now he has a more difficult to swallow, many problems coming. So surgeon doesn't want to go again at this moment. So we decided to give some neoadjuvant setting multi-agent chemotherapy to give hopefully will eradicate the tumor, or at least we can assist the neurosurgeon to go second look surgery. So we gave the chemotherapy with vincristine, cisplatinum, and the BP16, and endox for the cyclophosphamide according to the US protocol. And then the tumor didn't change much after 2 courses, but I asked surgeon to go again. So he went into, and after, this is also residual. Oh, sorry. I don't have a picture after the surgery, but the patient actually got the gross total resection after 2 courses of chemotherapy. And the neurosurgeon said it was much easier for him to do the surgery because the less bleeding and the tissue are not so sticky to the brainstem. So he was able to remove piece by piece those small residual tumor. And then patient went to the focal XRT 54 gray, and now only 14 months, patient have a disease-free survival, and only right facial nerve palsy persisted. So other cranial nerve palsy were improved. So now question is the residual tumor of posterior fossa ependymoma. Should we go second look surgery or not? So this is the best result of the ependymoma in our history. This is from the St. Jude group, very famous paper of this excellent local control and excellent overall survival. So now ependymoma we can cure, but look at this. Not easy to see, but actually 125 patients, which is 82% of the patient got the gross total resection, which is unbelievable number. And if you read this paper, actually one patient went to like 7 surgery to get the gross total resection. So they are very persistent about the gross total resection. That's why they have such a very good result, which nobody can reproduce. So the COG took some measurement. So they gave the chemotherapy, this type of the chemotherapy, 4-drug chemotherapy to the patient with the residual tumors. So then this is a final result. The good news is if you give pre-radiation therapy chemotherapy, or pre-radiation chemotherapy, and patient had already 90% resection. So these patients start with a very small residual, less than 10% residual. Actually, patient had a same survival with a gross total resection and get the radiation. So this is a great example of the radiation helps to maybe shrink the tumor, and put the start line as the same as the gross total GTR patient. But on the other hand, if you have a large residual, actually chemotherapy didn't help. So which means surgery is still very important. If you leave a little bit, maybe chemotherapy helps. But if you leave too much, chemotherapy don't help, and the patient has a very miserable prognosis. And this is now current COG protocol, which says if you have a residual, go chemotherapy, and if possible, go to the second resection, and then radiation, go to the radiation therapy. That's a current protocol. And the preliminary data said 64 patients had a subtotal resection, and 60 patients are evaluable for the chemotherapy. Only 10% got the complete remission, which means eradicate the tumor. But 25 underwent second look surgery. So the chemotherapy helped to do another surgery. And then among them, 14 got the GTR. So out of the 64, 14 got the GTR, 6 got the CR, which means 20 out of, 20 out of the 60, 1/3 of the patient went to the complete remission by the chemotherapy and the second look surgery, which is good. So this is our protocol starting this year. So we had a Japan Children's Cancer Group we call JCCG, and the JCCG, this is the first time we are going to do the prospective multidisciplinary ependymoma study. We didn't have any nationwide ependymoma study before, so but we decided to go. So this is actually very similar to the US study which completed a few years ago. So we are trying to kind of follow COG strategy and see if we can get the same result or equivalent result if we have a better kind of nationwide setting. So this is a very challenging study because we are going to go through the 2 rounds of the nationwide central diagnosis. One is a central pathology diagnosis. So until we get the central pathology diagnosis of the group 2 or group 3, we can't start the treatment because the group 2 and the group 3 has a different arms. So we need to wait for the central pathology diagnosis, and at the same time, we have also imaging review. So we need to send the MRI to the central diagnostic radiologist to see if this is a really resection gross total or gross total number 2 or near total or subtotal. So they decide. The local doctor sending some report and we get the result, and then we can stratify the patient. If there is a subtotal, similar protocol, we give the 4 drug, 2 courses of the chemotherapy. If it's resectable, go secondary surgery. If unresectable or CR, maybe we can go to the 3D conformal radiation therapy, 59.4 gray at the most. Then, if there are totally removed and the grade 2 and the supratentorial, same as the COG, we try to observe. Otherwise, they go to the, even they got the near total or gross total resection, they go to the radiation therapy. So this is our prospective protocol. So hopefully we can have a similar result, and we will set our kind of our baseline of the ependymoma outcome. Conclusion, ependymoma needs multidisciplinary treatment. Now you understand, we need a biologist, we need an oncologist, we need a good radiation oncologist, and a diagnostic radiologist, plus surgery. And the surgery resection with focal XRT is standard, but subgroup, which does not require XRT, exists. And the chemotherapy may facilitate second-look surgery and potentially improve the outcome. New drug based on the ependymoma biology is needed. We are waiting for further improvement. And Japanese national protocol is ongoing, as I show. Thank you very much.